Okay, everyone, for the sake of time, we're going to just go ahead and get started. I know there may be some blocks somewhere on someone's screen. I've been working on it. I don't see it on my end. So hopefully we can just bear through with this um, and we'll just keep going. Right, so welcome to the Long Notes last webinar for year one. All right, so just logistics, please mute yourself. Don't put us on hold. This meeting is being recorded and slides will be available on the project website approximately 5 to 7 days post this webinar, business days. Our speakers will have Dr. David Odell, we'll have Dr. Kelly Chan, and Dr. Ryan Reynolds. So the agenda for today is the welcome. We'll review some data. We'll have some programmatic updates and reminders, a year two overview, Q&A at the end, and then the meeting will be adjourned. All right, Kelly?
All right, hopefully you guys can all hear me, though you might not be able to see all the screens, but like Shay had said, we'll post it online shortly. So this is an overview of the June through August data that you all submitted to us. So next slide. So for the data collection period, a total of 415 programs submitted data at the time that we had pulled it. There may still be a few more programs that will be included as well. And there were a total of 3,600 cases that were submitted. The average case level compliance continues to increase and is now up to almost 80%, so it's 79.6% from 76.2%. And similar to the last data collection, the median number of cases per program submitted was 7 and ranged from 2 through 4, with a few programs submitting 0 cases. And the graph on the right shows the distribution of cases submitted. And then on the next slide, we are very pleased to report that the total overall compliance on the program level has continued to improve. So the table on the right shows that over time, there was an increase in both the median and the mean compliance, with approximately an average difference of 22% for both, respectively. And on the graph on the right, you can see the distribution of programs. And if you compare the curve to last webinar, you'll see that there are currently many more programs who have reached the 80% compliance. Next slide. Okay. And then at the program level, the medium compliance has increased to 87% from 82% from the last data collection, with most programs ranging from 63 to 100%. There were a total of 222 programs with compliance at 80% or higher, and so far 113 of our programs that had a baseline non-compliance are now compliant. And the average improvement that programs have seen is about 15.7%. There were a total of 56% of programs that had an increase in compliance, with the median increase being 17%. And then for the remaining 44% of programs, there was no change or there was a decrease in compliant. So notably, 97 of those programs were already compliant. And then there were 91 programs that decreased in compliance. Next slide. These are the graphs that show the surgical factors that are associated with noncompliance. The left side shows the left bar shows the total number of cases for each surgery or approach, and the right bar shows the number of cases that were non-compliant. So similar to our baseline data, a higher proportion of wedge resections were non-compliant at 28%, compared to lobectomies with 18%. And then for the surgical approach, 36% of open cases and 26% of video-assisted cases were non-compliant. And then next, this slide shows the lymph node stations that were missing for non-compliant cases. So of approximately 750 non-compliant cases, 21% were missing target for both hilar and mediastinal stations. And then 68% of non-compliant cases had less than 3 mediastinal stations, and the remaining 11% had 0 hilar stations. And then the next slide will show the reasons listed for non-compliance. And this is consistent with previous data collections, with 79% of cases selecting surgeon did not perform the required lymphadenectomy as the reason for noncompliance. And then this was followed by other with 13%, and pathologists did not report the findings in synoptic format with 8%. And then the next slide shows a few reasons that we had received for other reasons for noncompliance. And these include previously discussed patient factors such as prior cancer resections, a lot of scar tissue, bleeding. A new one that we saw this time was a statement that at the time of dissection, it was difficult to tell if this was a primary lung cancer or a lung met from a breast cancer. And the other reasons include that an exploration was performed, but lymph nodes were not identified, and that pathology reports did not label the stations. And then next, we'll move on to either Dr. Odell or Dr. Jacobs for the programmatic reviews.
Thanks very much, Kelly. And I'll just a word just because I know this is kind of in the chat. We are aware of the boxes that are blocking components of the screen. Shay and Eileen are working on getting the slides posted to the website. Unfortunately, it's not something that we can share in the chat box itself. But you guys will have access to all of this data here shortly. Fortunately, the next few slides are a lot more kind of qualitative in nature, so there's not a lot of data to look at. So can we advance, please? All right, so just a brief reminder for the remainder of the year. The next data are due at the very close of 2024 on December 31st for cases between September 1st and November 30th. We also are putting together a year-end reflection survey. This will be something that will give you all an opportunity to let us know things that have worked well and ways that you've overcome challenges within your programs. It should be relatively short to complete, but this will help us really better understand how to serve you all better, not just in this project, but in future quality improvement projects that we run through the ACS moving forward. At the midpoint in February, we will kind of wrap up year one and have a call to kick off year two. There will be an ask for those of you whose programs have been lower volume and less than 2 cases per submission to also complete the re-aim tool with your team to kind of help you formulate approaches to the QI project moving forward. Shay, can we go to the next slide, please? So a little bit more on the year-end reflection. This will help us kind of better understand the barriers that you've encountered and the things that you've used to kind of overcome those barriers. This is both for sites that already meet the operative standard and those that are continuing to work. And it's really helping us to better understand how you've affected programmatic change. And as I mentioned, this will help our team to understand where to focus our efforts in year two for this project, but will also help us better understand how to support future QI projects. So this is really, really valuable for our team and hopefully for all of you as well. The link for this survey will be sent to the primary contact at the beginning of December with the link for the data collection. And there'll be a PDF posted on the website within the next 10 days as well to go over this. Next slide, please. So wanted to put a plug in and Dr. Factor, who will be helping to lead this webinar, will be joining us today. We've heard from you all that the ability to educate members of your team, particularly the surgeons on your teams, about the evidence behind the standard and the rationale for which from which the standard was developed is something that would be helpful for support. So this webinar, apparently you have to ask to trick or treat at, but is on the morning of Halloween, next Thursday, October 31st. It's applicable for really any of the surgeons who perform lung cancer operations, whether they be general surgeons, surgical oncologists, thoracic surgeons, cardiothoracic surgeons, and while it won't be eligible for CME credits, I think it will be a great forum and opportunity to kind of discuss some of the nuanced details that we've heard are really of interest to the surgical community. So just wanted to put that forward as an opportunity and a resource for all the programs that have goals or needs for surgical education as well. Next slide, please. So I wanted to talk just a bit about the plan for 2025. So very similar to our requirements for this first year, we'll be asking for kind of data submission and attendance at these calls. We'll switch our calls much more towards a kind of working and problem solving format, as you'll see somewhat today as well. We want to continue to focus on addressing your root causes, but shift towards providing you with some tools to help think about sustainability and how you continue to cement moving forward the changes and positive progress that you've all made, as Dr. Chan showed us earlier. Surgeon engagement is required for all teams, and we're asking that at least one surgeon from each facility either attend or listen asynchronously to the recording at each of the 4 calls over the course of the year. Again, the goal here is to really focus some of this education towards the surgical community as well. That attendance will be recorded as a very brief survey monkey form. The note here, and this is an ask from our accreditation committee, is that for those programs who have really kind of topped out their compliance, have been at 80% or higher for all data submissions, you've really kind of attained the bar already for the QI project and will not be eligible to participate in 2025. If at any point you dip below that 80% on those data submissions, even if your overall total is above 80%, we would continue to welcome your participation moving forward. Next slide, please. So if you participated this year and want to continue, we ask only that you kind of go to the website by January 30th and just note that you are going to be continuing your participation. We only need 1 response per facility, and we'll just want to make sure that we're including the right people in correspondence as a group. If you would like to add folks or feel like you need to add folks to your core quality improvement team, please use this also as an opportunity to check in with all the stakeholders locally and kind of rally support again. And then the first round of data that'll cover cases from December through the end of February will be due on the 30th of March.
Hi, this is Samantha.
Next slide, please. And then this is just an overview of the timeline for year 2. Again, new programs would be joining in February, and we'll ask for baseline data very similar to what we've done in year 1 from those programs by the end of February, with that first data call then at the end of March, and essentially an every 3-month kind of call schedule and data acquisition schedule, as we've seen. So with that, we wanted to kind of open things up to the group for discussion. We found and feedback from all of you that having some time on these calls to kind of talk about kind of challenges that folks have faced or answer questions is really of value. So we want to kind of open it up. If you could maybe just unmute and ask our questions. I think that'll be probably the easiest, because it might be difficult to see everyone on one screen with hand raises and things like that, but we'll just kind of be as orderly as we can. And as I mentioned, I think Dr. Factor is with us, as well as our whole team here. So happy to talk through any questions that you have. If you guys are feeling pretty good about kind of where you're sitting with your programs, and there are things that you want to share or successes that you want to share, that's also great. But want to be respectful also of everyone's time. So if you don't have anything that you need to talk about and you want to drop off, that's great too. So I open the floor up to the group. Camille, I see a hand raised.
Yes, hi, good morning. There was a question in the chat about surgical intent, and then I had the same question too. So basically for our site, we're finding that, as far as the actual surgical, the technical piece of the standard, we're doing great. But I know, my understanding is that surgical intent is not a measure of compliance per se. It's a way of identifying the cases that fall within the scope of this standard. But then, because synoptic templates are not required for these operative notes, it sort of puts the onus on the surgeon to sort of post-operatively write in their note that the operation was performed with curative intent or not. But I think like when we go look back at cases, and we find that it wasn't written down, it may be because the patient was not, eligible. It was not, the operation wasn't done with curative intent, but it doesn't clearly state that. And so basically it sort of relies on, either the registrars or others to sort of audit these cases to just double check, hey, was this, operation performed with curative intent or not? And so I guess, to the first question is, just to clarify that surgical intent, if it doesn't have surgical intent, does that mean that the case is compliant or not compliant? And then two, I don't know if if anyone else has any ideas for how to sort of address this gap.
Yeah, Camille, I think that's a great question. And thank you for bringing it up because it's something that we hear a lot. I can kind of field the first part of it, and then I'd love to hear from the group kind of what approaches to the second question are. But you are correct. If the intent of the operation is not for cure at the time of surgery, so there are perhaps circumstances where a lung cancer is diagnosed on final pathology, but wasn't known or expected at the time of surgery, and the surgeon didn't sample nodes because of that. Just because it ended up being a lung cancer, if that wasn't their intent at the time of surgery, that would actually not be a case that qualifies for evaluation. So even if it may be non-compliant, it's not included. It's an exclusion criteria. Very similarly, the example that Dr. Chan brought up in some of the feedback that we've gotten, I wasn't sure if this was a breast cancer metastasis or a lung cancer. That would also not be a curative intent case. That would be more a diagnostic case and would be excluded. So I think there are, some of these cases where it really may come back down to that chart level audit, or if things get flagged, talking with your surgeons and saying, hey, what was the thought process? Was this a diagnostic case? Was this a therapeutic case? What did we know this was lung cancer? This was curative intent. And maybe even having to readdress some of that documentation afterwards. So it's in alignment. It is something that I know we've had to do at our program. I think the fact that we don't have standardized synoptic reports makes this a little bit more difficult, but I think it's a very overcomable thing as well. I've talked to several programs where they've actually just implemented that at the local level, and brought in a line that talks about intent, not just for their lung cancer operations, but for breast cancer operations and other things as well, because it's something that they're interested in tracking locally. But I'd be curious to hear what if any solutions other folks on the call might have come up with for this.
I don't know how to raise my hand. Can you hear me?
Yes, we can.
Okay, I have a question and then I have a comment on the second part. So my question is for the cases that the lymph nodes are, spot on, they're fine, but the intent is missing, are they considered non-compliant?
No, that would be compliant. non-compliance is really, curative intent is really only something that would be an exclusion from evaluation. And I think most programs are looking at that only if we see kind of a non-compliant case.
So they don't have to add the intent?
That's not part of the standard, correct?
Okay. Even though it says it in the standard?
That's for inclusion, is a
Okay.
curative intent cancer opera. So it's sort of assumed that if you have a diagnosis of lung cancer and you've done a resection, it's sort of assumed to be curative intent unless documented otherwise. So I really view this, and I think our team really views this more as the exclusion criteria rather than an inclusion criteria, if that makes sense.
It does make sense, but I think in all fairness that should be written in the standard for clarification. I think it would be helpful because what I did this last round, we were compliant, but intent was missing on every single case. So I gave the medical record numbers back to the surgeon for the opportunity to amend the note.
Got it. Okay.
Yeah. So I haven't gone back to check, but yeah, I did ask it gave him the offer. I'm not his boss. Just put it out there.
I think from the standpoint of how the standard would be used by site reviewers or or others that are looking at compliance, the standard is really about the node sampling, not the intent documentation. So if they saw a resection with a lung cancer diagnosis, they would assume that it's a curative intent case unless documented otherwise.
And that's exactly what they say.
But I can give some feedback to the team that's kind of looking at writing and revising the standards. I don't know if Dr. Factor is on and can speak to that at all as well, but that's something that we can definitely feedback, but it's not as clear as it needs to be.
That would be appreciated. Thank you. Thank you so much.
And then Cindy, you said you had a comment to Camille's question as well?
No, I wanted to ask if it was compliant, and then I wanted to share what I had done for the non-curative. Okay. I'm all done. Thank you.
Great.
I'm sorry.
No, go ahead.
This is Barb Short. We actually created a smart phrase in Epic that the physician could answer what the intent was, and also document the notes that he has taken. And that's been helpful.
So
great, thank you.
So hi, I got feedback from our surgeons that they weren't going to document they weren't going to start documenting in the medical records if it was curative or non-curative intent. And so when we audit it, it's the cancer registrars going through it to see if it was for curative or non-curative intent, because I mean it's pretty it's a lot of the non-curative intent, the ones you could see that it was non-curative, but it's an interesting one, unless even if you the standard says that you must document if it's curative or non-curative, which makes sense. Like for the 4 operative standards, it will take a while for surgeons to start doing that. So I don't know like how strict you want to be. Is it the documentation? I kind of like that it's not part of the standard yet, and we try to work it out without being dinged on it if it's not in the medical record.
Yeah, and I think that's an excellent point, because what we really want the standards to be about and be focused on are things that make a true difference in how the patients are cared for and managed and their oncologic outcomes at the end of the day. And we have really good data that lymph node staging does that. I think what we don't want to do is create a bunch of documentation hurdles to ding programs on. Now, whether or not we document curative intent in every operation or only document when it's not a curative intent case as that exclusion criteria, I think it may be of some value to have that be a decision that kind of falls to each program, how they'd like to treat it and how best to work through it. And that's probably going to vary program by program. But I do think there's an opportunity for us to at least kind of clarify the documentation piece of curative intent or not in the operative note is not part of the evaluation for the standard, if that makes sense.
Okay. I have a comment and a question from, we have a thoracic surgeon, Dr. DeBarros on the line. She says, I am a thoracic surgeon and I do not see higher bleeding complications in getting the required amount of lymph nodes. Her question then is, what about when you suspect lung cancer, perform a frozen or wedge resection, and then do operation with curative intent?
Yeah, I think that's a great question, and I think Dr. Barrios for bringing that up because we hear that kind of uncertainty a lot in one-off emails. So I imagine it's something the whole group has some interest in. That lung cancer diagnosis or assumed diagnosis doesn't have to be biopsy proven before you head to the operating room. And in fact, I think most thoracic surgeons would say the vast majority of our curative intent resections are exactly what was just described, a wedge resection and a frozen in the operating room that then proceeds on to, to a more formal curative intent resection. And that would be something that we would consider an evaluable case that would qualify. So you don't have to have a biopsy proven diagnosis before surgery in order for those cases to count within what's evaluated under the standard.
Okay, so I have if a patient had a curative intent surgery with adequate lung node removal during Q1 submission and had curative intent excision in Q3 for residual cancer with no lung node removal count for both quarter report, will the pathologist need to include the Q1 lymph node data as part of the re-excision to make the case compliant?
If this was a re-excision for like a positive margin or something like that from the first one, then I think they would all have to be on one synoptic pathology report in order for it to be compliant. If that same patient had two different primary lung cancers, then they would be evaluated separately and would each need to have adequate lymph node staging associated with them. So if there were no nodes taken in the second one and it was a different cancer, a different site or presumed to be a different site, then that first one would be compliant and the second one would be non-compliant.
Okay. Next question. If a patient has ambiguous terminology in a CT / PET report and a wedge resection is performed, no malignancy known prior to the wedge, just a note in the CT report that says suspicious for malignancy, does this case count towards this standard?
I think it would depend on what the intent of that operation was. And this is exactly that curative intent question.
Mhm.
If it was a wedge just to get a diagnosis, then that would not qualify for evaluation. If the intent was to treat this as though it was a cancer and that wedge was intended to be therapeutic and was assumed to be lung cancer at the time, then we would count that case for evaluation and appropriate lymph node staging should be performed.
Okay.
So this is an example where, to better understand that case, it probably needs to loop back to the surgeon who performed the operation. because you could have that scenario mean a number of different things.
I'm looking at all the other questions. They seem a little bit redundant. Did I miss any question that you feel that hadn't got answered in the audience here? You can unmute yourself, please, and speak up.
Hi, our center, most of our non-compliant cases are actually due to lymph node stations being removed, but only fat tissue being found on final pathology. So what's the recommendation to kind of get us compliant and make it so that this doesn't happen? Because they're labeling them as lymph node stations, and then, you know, there's only fat at the final path.
Yeah, I think, and that's another, you know, kind of common scenario that we hear from programs. I think that's an opportunity for the surgeons to kind of take a deep look at you know, their practice where they're looking for lymph nodes. There are some wonderful videos on the project website that could be examples there. But, you know, oftentimes this is just a matter of kind of not being in quite the right place when you're doing that staging. And sometimes it happens. And that's why the standard is set at 80% and not at 100%. Because we recognize sometimes when you're doing an operation, the final path doesn't necessarily match up with what you're seeing. But if you're seeing that as the majority of cases, that's probably an opportunity for kind of a deep look and opportunity for technical skills improvement. And we're working on some tools for that.
Would you say the same response to if the surgeon is looking and examining and they're calling out stations in their op report that they did not find lymph nodes, and then you end up having less than 3 mediastinal lymph nodes? Do you think, is that adherent or is that surgical technique?
So I'm going to split that question up. If you look at a node but don't actually sample the node, that does not count as an adherent case. The source of truth is, do we see the node on pathology? And the reason for that is if we've adequately sampled nodes, and Dr. Howington put this in the chat, that we will see about a 15% incidence of stage migration or upstaging. And that's really important because those are patients that should be getting systemic therapy. Just looking at a station and saying, well, I didn't see anything there, doesn't help us actually move the needle on that data and impact patient care appropriately. If folks are looking and not seeing anything, there are more than 3 mediastinal stations. So if you, and there are some times where you'll look and you'll say, hey, I don't see a level 9 lymph node. There are other mediastinal stations that you can look at and get to 3.
Well, that's what I'm seeing. The majority of cases that in our institution aren't passing would be where the surgeon might collect 2 or 3 stations and then say, but there was no 2s or 7s, but they sent 4, 6, and 9, and maybe only 2 of those actually had lymph nodes. So I'm counting that as non-adherent.
I would agree.
I just want to confirm, is that correct? Because you have to
that
have
is,
the
I think the way you're
lymph node
treating that is correct.
in the station, no matter how many are collected, if it's fat or if they say there were no lymph nodes seen in the station exam, and that's still not adherent. That's
correct.
not a pass.
Yeah, that is not a pass. That's correct.
Okay.
Jane, I see your hand up.
Thank you. Yes, I just want to make sure. So we have a cancer committee meeting on December 3rd. So my plan is on December 2nd to try to, we have a spreadsheet that we're running, that shows our cases are compliant or not. So we've been kind of tracking that on our own without needing, what's sent through the REDCap, data entry. But so if I report at that December 2nd meeting, you know, here's how many cases we did this year, here's our percent of compliance, and, you know, try to kind of wrap that study up for 7.3. Is there a verification that comes through, you know, through the study people that lets our next surveyor know that, yes, we participated in this study and, you know, for credit or whatever?
Yes, I saw that question in the chat. I was going to address it. It comes out mid-January, once the year wraps up, and then we have everything in place. I review everything, make sure that you met all the requirements, and then we send it out. So you should have it mid to end of January 2025 is when you'll get your letter of attestation via RedCap.
Thank you.
You're welcome. See a hand from Jill, if you want to go ahead.
Yes, and I don't know if you guys would know the answer to this. When we're surveyed, so let's say we have a survey in 2005, and they're looking at our path reports, are they just going to look at 2024, like the last year when we really improved, and not go back to 2023 where we weren't as compliant?
Typically look in the last year.
Okay.
You know, what I would say, however, is that, you know, if you're surveyed next year, the fact that you've been participating in the program is your pass for this.
Right. Yeah. And it's really for, I mean, it's for these standards, and also, which not part of this at all, is the synoptic op reports, where if you had a lot of problems in one year and you fixed it, and you could show the next year you were more compliant, like, why would they audit the year that you were bad? Unless the year you were bad was the second year and not the first year. So
correct. And usually what happens is they're looking at a subsegment of cases. So typically when that site review frame goes back further, it's we tend to see those problems more where what they're looking at is something that's a relatively low volume for that institution, where they need to go back multiple years to get enough cases to review. You know, for most things, looking at like 10 to 15 cases.
Yeah, that makes sense. Thank you.
I have a question, just to clarify. So to participate for next year, we would, it's a requirement that one of the surgeons is on the calls or at the meeting. We can't
either on the calls or that they listen to them asynchronously. So everything will be recorded and available, and that we just ask that the surgeons are looped in and listen to those as well. We understand that, you know, that the timing is not going to work for, you know, for folks to clear schedules at the time that webinars are set up necessarily. So all the surgeons would need to do is listen to it kind of at a time convenient for them. And then there's just a very brief RedCap survey where they essentially attest to the fact that they've listened to it. The reason that we're adding that in is the feedback that we've received from many programs, that the opportunity for the surgeons to have heard some of the things that we've talked about would have been very valuable as a tool to kind of get everyone on the same page. Recognizing that, you know, in many programs, it's the ODS or a quality improvement specialist who's maybe non-clinical, who is, you know, the primary person attending these meetings. So we just wanted to make sure that, because most of what we're seeing as reasons for non-compliance center around the actions of the surgeons, that we have we've given you another avenue to make sure the surgeons are well bought in.
Okay. Thank you.
Yeah.
David, can I ask a question? Yeah, so we are not at the 80% compliance rate, and we will need to participate in year 2. And I'm sorry if you've already covered this question, but will year 2 also cover our quality improvement measure, or will we need to do another quality improvement measure in addition to staying on the RedCap's QI?
Yeah, Shay, correct me if I'm wrong, but I believe it continues to cover both for year 2.
Correct. It's going to be the same as year 1, 7.3 and 5.8, correct.
Okay.
And Shelby, your hand is up.
Yeah, just a quick question. When we were previously surveyed, the auditor had conveyed to the cancer care program director and the surgeon when they were meeting about this standard, and it was determined that we were non-compliant. One of the surgeon's questions was, what if, I'm not able to collect the appropriate amount of mediastinal or hylar stations? How does that work? And the surveyor had conveyed to the surgeon at that time that as long as it's written in the synoptic path report, basically, detailed in the comment section, that it mentions the station that couldn't be collected, that we still met the standard. Is that correct? I'm just hearing some of the conversation and kind of inferring from there that that's probably not a correct interpretation.
That is incorrect. I actually have gotten a couple of calls about that in the last week. And I forward, I think that's a site auditor who needs some re-education. I've already forwarded that to Aaron Blesnick, who oversees that program. So Shelby, maybe offline, if you could just let us know your institution and kind of roughly when that site visit took place. We won't name you, but we can figure out who that auditor was and make sure that they're on the same page in terms of what the standard does and does not accept.
And you can inbox the Cancer QI with that information, and I'll forward it to Dr. Odell. And then
Okay.
we'll go from there. Thank you.
Okay, perfect. Thank you.
Mhm. So a question, can we participate in year 2 if we were compliant this year? That was addressed in the slides. And unfortunately, that would be a no. Reason being is the accreditation just thinks that maybe you all can address another quality issue that you may be having at your site. So for this year, moving forward, we're just gonna work with the non-compliant sites.
And that's only if you were compliant in all 4 of the data submissions. So if any of them fell below, then you still qualify to participate in year 2, even if overall you were above 80% for the whole year. But I think I just want to, for those that have kind of met that mark and will be dropping off, I want to really give everyone a lot of credit and thanks for all the hard work that they've put in. This has really been one of the most immediately successful national QI projects that we've done as a cancer programs group. And you should all be really, really proud of yourself for moving the needle. So thank you. Jennifer, I see your hand up.
Yes, hi, thank you. So for our institution, just want to make sure I'm clear. We showed improvement over the year with, performance in the 60s, then 70, and then we have reached 80 at the last submission. Are we still eligible to continue?
Yes.
Yes.
Okay.
You are. So it's only if you've been above 80 for all 4 submissions.
Okay.
Because the QI leadership really felt that if you're kind of already there and you've stayed there for a while, you've shown already that you know how to sustain that high quality. They still really feel there's value in continuing to participate for programs that are kind of fluctuating, that may get there and may dip down or may have just gotten there, and need to make sure that they have the tools and the time to sustain that improvement.
Thank you.
Alicia, you said, just to clarify, the surgeon should be attending the October 31st webinar. When Dr. Odell spoke on the surgeon's participation, we were talking about 2025's participation. However, if they can attend the October 31st webinar with Dr. Factor and others, that would be great because again, it can address some of the questions we're constantly seeing. So we encourage everyone and anyone to attend that webinar if you can.
But not a requirement. And
Correct.
that will also, I believe, Shay, that'll be recorded as well as a resource going forward.
Yes.
I have a question.
And then Bob, put in the chat, how to confirm whether or not they've had all 4 submissions above 80%. That's something that if programs have questions, please just reach out to Cancer QI and we can get that data for you. Cindy, go ahead.
If my facility was over, within compliance for the lymph node dissection, but not with the intent for the whole year.
The intent's not required.
Yeah, intent is not required. So
Right.
it would be considered compliant for the year.
Okay, so unfortunately, though, I consider them non-compliant in the survey because that's what was communicated. So can I go ahead and then just, let them know that the lymph nodes were within compliance, so we don't have to participate?
Yeah, we can dig into that with you offline too, if that's
Okay, I'll see what they want to do as well.
Yep.
Okay, thank
Great.
you.
No problem. Thank you. Jill, I see your hand up.
Yep, I just wanted to comment that I'm so glad that you did this quality improvement project because just by telling everybody that we were participating and that we were monitoring, even though we were monitoring before, it changed the behavior of some of our surgeons that were not compliant just because they just didn't want to be bothered with being notified that they were non-compliant, and they didn't want to argue about it anymore. So as long as they felt it was safe, they may have disagreed with sometimes removing the lymph nodes, but as long as they felt it was safe for the patient, they started doing it. So so you really helped us just by having this meet the standard. So thank you for having it.
Well, thank you so much. I appreciate those kind words, and that's the type of impact that we hope to be able to have is giving us all the the strength of numbers to be able to move cancer care forward across the country. So thank you.
So we had Tammy, if we are a low case facility, can we participate in 2025? And are we going to be rated compliant with the study if we have cycles without cases? So the ask is that you at least perform 1 or more resections during the year to participate in the QI study. Were the webinars required in 2024? They were not. This is a new requirement again for 2025. And again, we're implementing this based on the feedback of it's hard to get surgeon buy-in. So maybe if they join the webinars and listen to the webinars, maybe they can then come with their concerns and it can be addressed then. So this is why we're implementing it for 2025. Will there be a message?
And then
I'm sorry, go ahead,
I
Dr.
see Barbara's question in the chat. There will be 1 more submission this year. So, I think we probably don't yet know who is compliant for the whole year and not yet. I see Lori's question about, do we need more than 20 cases? We do not. And then a couple of folks have asked questions about what the surveyors will look at. And the path reports are considered the source of truth. So that's what they'll look at primarily. I see Dr. Factors joined and has his hand up. Matt, go for it.
Yes.
Hi, can you hear me?
Yes, we can.
Okay, good. Sorry, I've been mobile. So I was careful not to speak up earlier, but just to sort of chime in, I was one of several who were sort of in the room when this happened, when we created the standard. And I'm really glad that we're getting some clarification and whatnot. And because there's always unintended consequences, of course. And the issue of the curative intent, and maybe we're beating it too much here, but again, just for a little bit of clarity, just wanted it, you know, of course, it's a case that for any reason, this isn't a curative intent procedure, that doesn't need to count for the standard. That's really all that was intended. And, you know, by and large, all of these cases are going to be with curative intent. We don't do many lung operations where it's palliative, except for, like, you know, a malignant pleural effusion, and that's a little bit of a far away example, but there's going to be some other examples. But like the case of the you know, we've got a nodule, it's suspicious on CAT scan, PET scan, but we don't know if it's cancer yet. You know, in the absence of metastases, you're damn right the intent is curative. You don't know if it's cancer yet, but you're going in there. Maybe it's a diagnostic wedge first, maybe it's a diagnostic lobectomy, but you're not coming back another time for that patient. If it's cancer, you're taking care of your business, you're taking care of the lymph node deal, because you may not know, even on frozen section, it may not be accurate. Obviously, they're very accurate, but nothing is 100%. So, I mean, you should not harm the patient and be bringing them back a second time to the OR to finish the job and do the lymph nodes. If it ends up being a breast metastasis, that even still may be curative intent, but it's not for this standard. That's obviously a different diagnosis. So like Dr. Odell said, it's really more of an exclusion thing. There's not going to be many instances of that. But I completely understand, and certainly we can work on language as far as how that can be a little bit confusing. But literally the other idea of the standard was just to remind folks that, yeah, you shouldn't be planning, you know, 2 operations to get the same job done. And so, of course, it's with curative intent. And you know, there are some exceptions, of course, but that should also be well documented. And yes, I would love to see synoptic op reports. And that would definitely help where curative intent is one of the drop downs. And I do find myself a lot saying things like, here we are, this is a diagnostic therapeutic resection with curative intent, just to be absolutely true and clear. You know, when we're going to the OR with a suspicious nodule, twice in the last week I've done that. And so my wording, just to be totally clear, was what I just mentioned, but apologies that has become kind of a confusing thing. And then the final thing is that we all take some samples out and it turns out to be fibroadipose tissue or whatnot. That's okay. You're trying, you're looking, you're trying. You may not be able to recognize that it's a lymph node or not, but keep looking, keep looking. Our job is trained, those of us that are trained general thoracic surgeons, lymph node harvesting is all part of our training. And of course, there's danger in any operation, but we're trained to avoid that danger. So when we hear those sorts of explanations that just generically, oh, there's way more complications when you take out lymph nodes, the STS database verifies that is not true. Of course, there are cases where it's too dangerous to do this or that or whatnot. No problem. Be safe. And that's why it's an 80% compliance, not a 100% compliance. And looking forward to next week's webinar. Dr. Vera Machinini and I will go through some of the the references, the research behind all of this as well. So thank you.
Thanks, Dr. Proctor. Erin, I see your hand up.
Yeah, thank you. I just had a quick question. We are an INCP with 2 locations. One of our hospitals has been compliant this entire year, the other has not, but our overall program compliance is over 80%. So how would that affect our ability to participate in year 2?
Shay, correct me if I'm wrong here, but I believe it would not fall to the overall program compliance. It would look hospital by hospital.
Correct.
So the hospital that has, if that hospital remains compliant in this last data set, the one that's been over 80% would not be eligible, but the one that's under 80% would be eligible to apply as the individual hospital. But this would not then count as the program or the INCC program level QI project.
Okay. Thank you.
Yeah. Shay, did I get that right?
Yes, you did. All right, so it looks like we're 2 minutes to the end. Have we addressed everything? Want to thank you all for participating in this webinar. Thank you for your patience with the slides. Don't know where that came from on my end. I was not seeing the blocks that you guys were seeing. So I attribute that to a Zoom technical issues. We have noted your recommendations for the next time. And again, just want to thank you for bearing through that. I know that was kind of annoying to have to. All right, so if we have nothing else, we will wrap it up.
Thank you, everybody, not only for your participation today, but for your work on the project all year long. You really moved the needle and it's great to see. Keep up the great work.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.